Okay. It is a pleasure for me to welcome you to today's installment of our interdisciplinary lecture series. This is our 43rd year. And of course, the theme this year has been advocacy in healthcare and medicine. Before I introduce today's speaker, I do want to remind you next week on April 9th, Dr. Marian Danis from the National Institutes of Health will be our speaker. And so I'll encourage you to come back next week. Today, it is my pleasure to introduce our speaker, Dr. Sally Satel. Dr. Satel is a resident scholar at the American Enterprise Institute and the staff psychiatrist at a local methadone clinic in Washington, D.C. Dr. Satel was a graduate student here at the University of Chicago some years ago. She did her psychiatry residency at Yale University and then stayed on the faculty as an assistant professor from 1988 to 1993 and remains a lecturer at Yale. From 93 to 94, she was Robert Wood Johnson Policy Fellow at the Senate Labor and Human Resources Committee. She has written very widely in academic journals on topics of psychiatry and medicine. She's published on cultural aspects of medicine and science in numerous magazines and journals. She has testified before Congress on veterans issues, mental health policy, drug courts, and health disparities. She's the author of multiple publications, and I'll just mention a few. Drug Treatment, The Case for Coercion from 1999, PCMD, How Political Correctness is Corrupting Medicine from 2001. She's the co-author of One Nation Under Therapy from 2005, co-author of The Health Disparity Myth from 2006, editor of When Altruism Isn't Enough, The Case for Compensating Kidney Donors from 2009. Her recent book, co-authored with Emory psychologist Scott Lilienfeld, is Brainwashed, The Seductive Appeal of Mindless Neuroscience. And I do want to note that that book was a finalist for the 2013 LA Times Book Prize in Science. So it is a real pleasure to welcome Dr. Satel back to the University of Chicago. So welcome.
Thank you. Thank you so much. And thank you for inviting me. And thank you for starting out with such provocative titles, because it got people, oriented, I suppose. So I was telling Micah before, when you live in DC, you don't give talks, you're on panels, okay? Which means you speak for 5 minutes and so does a person next to you on down the line, and then you talk, then there's Q&A. So I don't remember the last time I've spoken for 45 minutes straight. So, so I'll be cued as to my timing. Anyway, so that's my title. And, but it's really about physician advocacy and its discontents. That would be me. And so I am going to start off a little bit talking about transplant policy, because it's something I have a truly organic interest in. So in 2004, I went to the doctor, GP, for a checkup, because as a good physician, I hadn't been in 10 years, right? And so for those medical folks out there, surprise, my creatinine was 5. And obviously that's a big red flag for renal failure, or at least a renal problem. But it must have been very gradual. You can lose organ function very gradually and not sense it until it's really too late. So I was about to be too late. And, I knew what that meant, that I'd have to find myself a donor. And because I didn't, everyone knows a preemptive transplant is better. And I certainly didn't want to go on dialysis if I could avoid it. And so there began my search for an organ donor, which started out very, did not start out well. People, got cold feet. I get it. You can't really complain. And, but and I really, though, wanted to be able to buy a kidney at first, though, not because towards the end I desperately needed one, but because I didn't want to have what, if you're familiar with this book from 1992, Spare Parts, the authors, Renee Fox and Judith Swayze, a sociologist and historian of medicine, they wrote this. They've really been great chroniclers of the history of transplant, and they wrote this book called Spare Parts, Organ Replacement in American Society, and they coined this term, the tyranny of the gift, which meant, and in fact, they described it as, quote, the giver, the receiver, and their families find themselves locked in a creditor-debtor vice. And that's how I thought about it, that I just thought I would owe someone so much that it would just be dislocating to me. And I wanted to keep it anonymous, the good, in the Adam Smith tradition. And, but eventually, actually, it turned out I wanted to buy one because no one would give it to me. And I tried to go on. I'm sure you've heard of these kinds of things. This is matching. It's a little busy slide, but basically it's something called matching donors, which is like a J date for people who need organs. I'll call it a K date because I needed a kidney. And I actually got, anyway, someone was going to do it and he backed out. And meanwhile, dialysis is looming. And anyway, the story ultimately, well, this is how desperate people are. I'm sure you know all this. This is not a lecture on the tragedy of the kidney shortage. But in any case, I did consider briefly going out of the country, but finally, a friend heard from a friend who, thank God, did not respect my confidentiality when the person said, how's Sally? And said, she needs a kidney. And that person, thank God, is Virginia on the left side of the screen, who's maybe well known to people who have a libertarian streak. She's a journalist and a really brilliant woman. And yep, she gave me a kidney, and believe it or not, I ended up meeting another one a few years later. And Kim, who had sort of watched me go through this ordeal of trying to find someone, was trying to have children at the time. And she said, look, if you need another one sometime, I'm keeping it warm and you can have it. And so thank God she did. And thank God both these women, their husbands were on board, because that is something I hadn't appreciated, how much the family had to be on board. So that was all great. But the whole issue really galvanized me. The idea that 12 people a day died because they weren't lucky enough, and this was in my case, to have a family member who could do it, or a willing friend like I did, that they should perhaps die, prematurely, or languish on dialysis for years, which I realize, thank God it's there. It's a mediating technology that people with liver failure do not have, but still, it's not a life that most people would choose. So I just couldn't believe, as I got into the ethics of it, why can't I buy one? And I was really, really struck by the fact that some folks, some folks in nephrology, some folks in transplant, some bioethics folks, just seem to be more concerned that a willing, well-informed, well-treated potential donor might be compensated for giving an organ. We're more concerned about that than the fact that someone could die. And so basically, the position we're in now, and there's still around 12 deaths a day, is that we're living under the tyranny of altruism. And yes, I'm the poster girl for altruism, obviously, but it's not enough. And that was the title of the book that Peter had mentioned. Altruism is not enough. And I'm sure you're familiar with all the formal arguments. This is the book in case you need any arguments. All the authors, admittedly, were in favor of this concept, but we tried to be as fair-minded as possible in terms of dealing with the folks and the arguments that disagreed with us. I don't know however fair-minded you can be about that when you feel so strongly about one side, but I like to think we did so, at least when it came to what Michael Sandel made a distinction between arguments from corruption versus arguments from consequence. And arguments from corruption probably Leon Cass is not a figure in most of your memories, but he was a brilliant doctor. And I think he was an honorary philosopher. I don't think he had a degree in it, but who ran a lot of bioethics here. He's very much against it. He's a proponent of dignity arguments. He stated them more eloquently than anyone could. Obviously, I don't agree with them, and in a way, I don't understand them. But then there are the arguments from consequence, which is basically the utilitarian view, the consequentialist view, and those can be, you can make those in a much more standardized way and to see what's empirical and what could be solved that way and what's a logical proposition and how you could argue one way or the other. So this book, in case anyone's interested, has all that in there. And so then I found out, I kept working on this issue, and with a colleague of mine who's a tax expert, we came up with a tax plan that is now actually in a bill in Congress that hopefully will get passed, but these things are all uphill. And that bill is called I never had a cover story. I had one in tax notes, so eat your heart out. Or kidding. And so this is called the End Kidneys Death Act. And it would make it legal to give, it's really a tax bill that through the IRS, that anyone who gave a kidney to a stranger would receive a $10,000 refundable tax credit every year for 5 years. And we can even talk later about that if you want. But the point is, this is my advocacy. So this is in a way the pinnacle of it, that the law, would be changed. And I'm not the only one doing this. Again, folks in transplant would know Arthur Matus. Certainly, these are physician advocates. He's wonderful. He's at the University of Minnesota. I'm another high-profile person in this area is someone named Ben Hippen, who's a nephrologist. He was an academic, but he since actually works for a dialysis company now. But anyway, so this is physician advocacy. I guess I was patient advocacy, but I always felt that I had a bit of an entree because I was also a physician as well. And I know that Ben and Art, I think it really lowered their thresholds. I think they'd be open-minded to anyone who wanted to engage with them, but it was a great entree. And we all, gave Hill briefings and wrote op-eds and all this, as a way to change this reform. So I start with this and use it as kind of a case study of what I would consider constructive physician advocacy. There's all kinds of constructive physician advocacy. There's arguing for the Medicaid that will probably be cut. There's lobbying for getting a federally qualified health center in your rural town. There's informing local authorities about the risk of roaches in children with asthma. I mean, these are all issues, and there's so many more, that doctors, I feel, have a legitimate role in advocacy. And what they all have in common is that they are promoted by people who are deep experts in the area. And the policy change or the reform that they're arguing for is what I call very proximate to health. It's not way upstream. It's, if we could change this, people would benefit almost immediately. So the rest of my talk really is contrasting that kind of advocacy with what seems to be very popular in medical schools, and even in, I think, doctors' understanding, young doctors, or at least what some of them beginning to see as part of their identity as physicians. And so this is very, very, to me, very important area. Now, some of these examples I'm going to give may seem like straw men because they might strike some of you as over the top. They certainly strike me as over the top, but then again, it's the University of Chicago, thank God, and bastion of neutrality. So hopefully you will. You don't have to, of course, but share some of my concerns here. So I'm going to talk now about these categories that I just made these up. but developments in these categories of what I consider risky physician advocacy that I think don't serve our profession that well and don't serve our patients. So under the first one, so here are the examples that, again, you may disagree on their legitimacy, but this is from 2014. I'm sure these pictures look familiar to you. This is a die-in. I don't know what medical school that was. And in 2014, you may recall, that was the death of Michael Brown, and he was shot by a policeman. It's a young Black man in Ferguson, Missouri. And so anyway, this is doctors. And this happened at least 70 other schools, I believe, at the time. It was an organized protest. And then out of this came a group called White Coats for Black Lives. You may or may not have heard of, but their agenda is very progressive. They, of course, would endorse that themselves. Here's another example. I don't have a picture, but you may recall this article from the Times. Was last year, last June, that doctors and medical students were protesting on the medical campus. Patients could hear them screaming intifada in their own patient rooms. A lot of these doctors are wearing keffiyehs, which they can wear on their own time. That's fine. You can do any of this on your own time as a citizen. They were wearing little, watermelon pins. According to this article, the UCSF didn't seem to take much action. I don't know what happened. It obviously died out, but that is really quite concerning. I don't think we spend enough time thinking about how patients feel about these things. And I don't think you have to be a Jewish patient in a room to worry, just to even have the worry that maybe my doctor, because my name is Goldblatt, isn't going to be taking as good care of me. Probably he would, but just to have that worry is I'm very opinionated about this. I think is quite unconscionable. And then another example here, which is maybe a little more obscure and more subtle, and I don't, well-meaning. So this was about a group called Vote ER, ER meaning emergency room. It started in the emergency room. This idea that it's doctors' role to get patients to vote. And apparently, according to this article, more than 50,000 doctors voted to register their patients. I mean, their patients had to be willing, to inform them about how to vote. They had little QR code things. And the American Academy of Pediatrics, American Nurses Association, AAMC, they all were on board with this. And as you can imagine, I think this is problematic. So why is this problematic? I don't think I have to really describe much about the first few examples because, again, I think they could really damage patient trust. But the way this voter ER used their operated was the schools could apply for money to buy the have the QR codes but the application for the QR code was whether the majority of you got a higher score, a higher likelihood of getting those funds if the majority of your patients were 24 years or younger, Black and African American, or LGBTQ. Sorry. So clearly this was a democratic recruitment effort and exploiting, in my view, the doctor-patient relationship for political ends. I would say the exact same thing if their questions were, are your patients white? Are they more likely to be over 65? Do they watch Fox News? So this is independent of which side these folks were biased in favor of. But the point is, this was mobilizing the medical encounter in which a patient should think that you, the doctor, are thinking about nothing but them at the time you're with them. And bringing up voting, I just can't imagine how that alienates so many patients. And even if a few like it, think about how many it alienates. Okay, I'm moving on. So then I'd mentioned on my other slide, I think some of the activities more mission driven, more more of an umbrella type thing. And, we've seen this after the murder of George Floyd. We've seen things like this. That's dated 2021, but there was an earlier version from 2020. So you can see it, confront inequities, dismantle. From the AMA. The American Academy of Pediatrics went so far as to implore its members to, quote, dismantle racism at every level of society. Then there's this, I don't know how many of you guys caught it. It was a language guide. That's the next slide, but it was in a language booklet put out by the AMA about how to talk to patients. And here's an example. I guess I'll read it, but you get the idea. Instead of saying something, if you're teaching about the demographics of coronary artery disease, you bring in every cultural dimension you can think of. Can you imagine talking to a patient like that? So, and then finally, just my last example in this category are the Hippocratic oaths. And they're not doing their oath, but it just seemed like a good illustration. I mean, the Hippocratic Oath was written a hell of a long time ago, and I have no problem with it being updated, and it has been many times over the years. But let me read you what the incoming medical students during their white coat ceremony said at the University of Minnesota. And it's not alone. I'm not cherry picking. This trend is in other medical schools alone. Their oath is to promote a culture of anti-racism, unquote. They considered their own coats, which they said, a symbol of power, prestige, and dominance. That's what they thought of their own white coats. So they were committing themselves to uprooting the legacy and perpetuation of structural violence deeply embedded within the healthcare system. Okay, so I don't know what to make of this, really. This is their first day, for God's sakes. And the dean had previously called this a beautiful speech, so it's hard to know. Of course, you go along with what the dean says. But I don't know. I don't know if this is a beginning for these folks of an academic career in which many of them, see activism as part of being a physician. And maybe even primary and maybe a little secondary to learning medicine. So the other thing I don't know is how many students really endorse this. I don't know if we're looking at a tip of an iceberg or the far tail of a bell curve. I don't know, but the most vocal people and some of the most vocal administrators are very sympathetic. So these attitudes and orientations do have a lot of clout. Okay, another example. Can I ask you what time it is? Oh my goodness. Okay, this always happens. Okay, I'll end with this one. I'm sure you've look at the top. That's what I'm most concerned about. This is public health. This has almost been iconic, but evaluating the benefits and risks of controlling the virus. Okay, well, first off, it's incoherent because you can't quantify these things at all. I do know what she meant, and I have no doubt she meant well. But this has been, as you can imagine, really criticized for one main reason, which is the hypocrisy. You can't imagine that they'd say if you need to, march for pro-life causes, please don't worry. Or go to church, if you're all spaced out, that's okay. So the hypocrisy was overwhelming. And remember, the public sees this. This is one of the main points here. But to me, what was even more outrageous is the notion that an epidemiologist not only gives you the risks, I mean, to the best of their ability. I mean, obviously it was hard to do at that time, but it's not only, that's their role to give us a thoughtful expression of what the risks are by doing certain activities, but that they saw it as they saw it as their job to tell us which risks were worth taking. That is a different order of magnitude. I think of misconstruing one's role. And it wasn't her. There were a million people like this gentleman who probably just lost his job because I think he was at the USAID, sadly. And then there was a letter written by 1,200 other health professionals who agreed with it. So anyway, I am going to move quickly. Okay, so basically, there's no question that so much of this is obviously in the spirit of improving minority health, and no one would disagree with that for a minute. That's a completely noble and cause, and it is again part of our cause. But the question is that if it is true, and it is, that minority patients have poor health status and poor access to care, is how do we try to change that? And this is where the differences, I think, of opinion come in, which is how do we interpret mechanisms that get people to optimal health? And that is the crux of so much of this advocacy. And it goes to an assumption that's embedded in so much of this advocacy today, which is that poor health is a product of upstream forces. I alluded to that before, but you could call them, I'm blanking on the name. Oh, social determinants of health, sorry. And I don't think I have to define that for this group. They're true. Of course, there are social determinants of health. The question is, what do physicians do with that knowledge? And what I'm suggesting is that there's a big difference between understanding the variables that impact health, the social determinants, and acting to affect those variables. And as what you can already infer from what I've said so far, that I worry that some physicians, are going beyond the boundaries of what I would call responsible investigation and clinical pragmatism. So let me outline what I mean by what I think is problematic about this. So the mandate for change, let's say dismantling racism, prevents doctors, or ending poverty, or prevents doctors with just a completely unworkable challenge. We're wholly unprepared for such a task. Our primary job is to diagnose and treat and be aware of the social dimensions of things, for sure. But we have no expertise in this. We don't know how to redistribute power or money, and we don't have the time to wait for the results of doing that. So by urging reform in the name of this kind of reform in the name of health, all good intentions aside, I really worry that doctors are abusing their authority as physicians, and that they're using the profession as a vehicle for politics and eroding public trust. But also, this mission is way too ambiguous, even for seasoned policy analysts. Teasing out the explicit and strong causal links, if they are there, between health and all these sprawling upstream conditions. And that's incredibly difficult, even for the people who are supposed to be doing it, the policymakers and the politicians. There's so many intervening variables that, you could change something up here, and by the time it seep down, trickle down to people on the ground, it's not unclear what helped them at all. It really is a manifestation of what a colleague of mine calls kind of Ebola politics versus abortion politics. And when do you listen? When do you give more weight to what the clinician says or the epidemiologist says? When you've got an infection that has a 50 to 90%, depending on the strain, death rate with Ebola, yeah, doctors then have a huge role in helping determine the policy. When you have abortion, there are probably some empirical matters that would help some people decide what policy they want to endorse. But in general, that is a very complicated matter of moral commitments and religious affiliations and frankly, in philosophy. And it's very hard to adjudicate. We know that because this particular issue has always been with us, will always probably continue to be with us, will always be contentious. It's very hard. So I would put what I'm talking about a little bit inside the abortion politics area, but not at the level of Ebola politics at all. And so when what we need for researchers to do, oh, I should say, in case anyone has any questions about my sincerity, there's no question that the poorer health and lower access to care is due to historical, legal, political, and social institutions that have historically discriminated, and at times the inferior treatment, which is either explicit or implicit, has been, something passively inflicted or, overtly inflicted. So all that's true. The question is, what are we as doctors supposed to do about that? What is the best thing we can do? We saw that in COVID-19. That was just an object lesson in, I think, some of these social issues and how they manifested in higher mortality and morbidity rates. So, so that's one of the, excuse me. So while all this is true, the question comes down to translation. Because I am going to now quickly go through the rest of my talk, I'm going to say that another problem, I realize, this is controversial, but that a lot of our default systems, when we talk about these health differentials, disparities, differentials, whatever, which are often labeled inequities, even the language there is kind of implies bad faith, before sometimes we even know what the variables are. I've seen so many articles, in my field, like, why are African-American youngsters more likely to be in restraints in emergency rooms? Well, it's a good question, but we can't immediately leap to the discrimination answer. That is a diagnosis of exclusion. And I've seen this so much in literature, and I'm sure you have too. Yes, there are some good studies that really are just, I'm neutral. I'm just presenting a correlation, end of story. In the discussion, it's more research is needed, to tease out what this is about. But I think we're getting, as a profession, a little bit sloppy about being that careful. I've also seen very dubious proposals that are attempting to use policy as in the spirit of reparations, or to kind of compensate for past social injustices. And we saw this too with COVID, that the advisory committee on immunization practices actually argued that from the CDC, that we should not give age as much priority as one would expect, since that was clearly the highest single risk factor for morbidity and mortality, because there were too many white people. They said this, there are too many white people represented in the over 65 or 80 group. And so we should downgrade them. Well, even the CDC staff told them, you're going to kill people this way. They ultimately were overridden, but that is remarkable. Also, there was far less well-known but similar spirit of discussion during when we thought ventilators would be needed, that again, the priority should go. I mean, when you have triage situations, they're always tough. Sometimes it's who's the sickest, who's got the best prognosis. Sometimes it's even first come, first served, which is kind of the case with kidneys. But whatever, those are at least recognized triage mechanisms. But this particular bioethicist at the University of Pennsylvania was suggesting that race be up there too. So you get the picture. So I will skip ahead to my conclusion, because I'm sure it's almost 22, right? I mean, 12:40, right? Okay. So anyway, I think academic medicine is in the risk of a pretty interesting and kind of risky institutional experiment, driven by the ideas that physicians should be political policy advocates. I want to say the word social justice, and then how do you define social justice? I'm just going to say you can define it by everything I've explained. It's an equity mindset, define equity, not equality, a guarantee of equal outcomes by almost by any means. And we want to get to the optimal outcomes. I think that's what our job should be. Equal outcomes are always going to be tough, but we have to try harder to get everybody the best help they can, so that the real health disparity is between their current health and their optimal health. For doctors, not public health people, they deal with groups, but doctors deal with individuals. So that's a tough one. And the demographic trends in our field are interesting, as everyone knows. Most new medical students are kind of left of center, which would be fine, but that just means their politics would probably coincide with this kind of agenda. And there's also so much burnout in young, in medical students that is interesting. And a lot of social consciousness, which again, I think makes them amenable to a lot of these causes. But really, if we believe that health is so dependent on malign social forces, does this mean, and I can't believe it does, so I can't believe that when the door is closed with you sitting with your patient with diabetes, you don't talk to them about diet, you don't talk to them about exercise, you don't talk to them about the things they can also do for themselves, while finding out if they have good electricity to keep their medication cold. You know, do they have good transportation to come to the hospital? Yes, all that, but we can't let up on helping, trying to teach patients how to take care of themselves as well. So I will say that when it comes to, oh, I have to show you my last slide, because who could talk about this without this? So Rudolph Virchow, of course, and he said a lot of things. He was actually, he's lost his position at Charité because he was such an activist, but he was a Prussian physician and pathologist. And anyway, but he did a lot of work on what we'd call the social determinants, but those days they were like no sewage and no, the real basic phase one of public health. But he also called doctors the natural attorneys for the poor. And I agree with that. When you're with your own patient and you're you're advocating for them personally, you definitely are. But when it comes to large policy issues, like the ones we've been talking about, ones that cost money, public taxpayer money, and that have to compete with other social priorities, the best we can do is, if we happen to be experts in that particular field, is to try to illuminate policy debates. But we're often not in the position, and I don't think we should be, of settling those debates. Thank you.